Hi, good afternoon, everyone. So I am Kate. I am a light-skinned cisgendered woman with dark brown hair, blue eyes, and I'm wearing a bright blue blazer. My background is blurred. The graphics included on most slides here are decorative and in the colors of pink, yellow, and blue color scheme because I like these colors. A little bit more about my social positionality. My formal education background is in liberal arts, psychology, art studio, public health, and social work. My informal education background is grounded in my lived experience with nature, embodied movement, meditation practice, and engaging in art communities. I have a chronic invisible illness and a mild learning disability, and I grew up as an only child in a two-parent household where my parents were well educated and most often employed and politically liberal. We lived in a rural community of the Midwest where I felt safe and witnessed figures of authority who reflected some of my social identities. So today, this project aims to understand the implications of applying a disability lens to public health. It accomplishes this through identifying contemporary value alignments and misalignments between the two fields by specifically exploring caregiving in the American rural context. Then, guided by models from each field, it attempts to provide a case study of how the field of public health might apply practices that are informed by values better aligned with a critical disability and/or disability justice lens. The following definitions of critical disability studies and disability justice are likely familiar to a large majority of people in the audience today, so I will briefly cover them. For the purpose of this presentation, I understand critical disability studies as a field of study, which through the application of a critical lens, starts to conceptualize disability as the space from which to think through a host of political, theoretical, and practical issues that are relevant to all. Disability justice, sometimes referred to as the second wave of disability rights, pushes this further, proposing guidelines and principles which center collective access and liberation across multiple systems of oppression. Here is a quick glance at the 10 principles of disability justice published in Skin, Tooth, and Bone. An excerpt from Skin, Tooth, and Bone, which I think elevates the important essence of the movement and the role of resistance, particularly prioritizing a pervasive vision of a world where all people who have been historically oppressed, such as disabled people, flourish and are valued and celebrated in all facets. So the quote on the slide says, "Disability justice holds a vision born out of collective struggle, drawing upon legacies of cultural and spiritual resistance. Within 1,000 underground paths, we ignite small, persistent fires of rebellion in everyday life. Disabled people of the global majority, Black and Brown people, share common ground confronting and subverting colonial powers in our struggle for life and justice. There's always been resistance to all forms of oppression, as we know in our bones that there have always been disabled people visioning a world where we flourish, a world that values and celebrates us in all our beauty." So switching gears, let's talk about public health. Possibly less familiar to this audience, the definition of public health here, I quote the Center for Disease Control, who defines public health as the science of protecting the safety and improving the health of communities through education, policymaking, and research for disease and injury prevention. The field also has 10 essential public health services that are aimed at achieving equity, promoting policies, systems, and overall community conditions that enable optimal health for all and seek to remove systemic and structural barriers that have resulted in health inequalities. Specific barriers called out in this 10 essential services include poverty, racism, gender discrimination, and ableism. Although contemporary public health has been situated as part of the health sciences, a seminal quote regarding the field states that medicine is a social science, and politics is nothing else but medicine on a larger scale. Public health is specifically recognized among the allied health professionals, such as nursing, medicine, and dentistry, as being attuned to the social systems which influence health. However, public health on the large majority prioritizes Western knowledge systems and has been a vehicle for enforcing imperialist and colonizer agendas. As a field, it also prioritizes medical models, biomedical, and healthism values. Here is a brief glance at the 10 essential public health services. You might notice discourse such as monitor, investigate, effective, legal, and regulatory action, which is a big divergence from what we saw previously when discussing disability justice. We also see a value directive, prioritizing improving health, even in services that center communities, such as number 4, which states strengthen, support, and mobilize communities and partnerships to improve health. So, considering the current state of public health and critical disability studies, there are a few areas of congruence. Both fields, on varying degrees, consider how environments and social systems such as sexism, classism, and ableism impact individuals and communities. Both fields also emphasize on the intersecting nature of social conditions, especially within the context of systemic oppression, which is more recent focus for public health and not a historical focus. However, there are far greater areas of incongruence and honestly a long history of harm from public health. Values of utilitarianism upheld by medical fields and promoted through a public health rhetoric have in countless ways directly and indirectly inflicted harm and promoted eugenics of people with disabilities. Additionally, the fields of public health and critical disability studies differ greatly on the approach to knowledge generation, especially when considering truth or determining validity. For example, public health values empiricism over narrative. Public health also often frames disability as a condition-based limitation and through the lens of experiencing barriers in the environment, often considered as social determinants of health. While this recognizes environmental barriers as playing a crucial role in disability, there is a huge incongruence between the two fields here because most public health discourse situates a deficit versus an asset view of disability due to the healthist values laden rhetoric within the field. We also rarely see public health rhetoric situate the environment or the systemic oppression as the disabling actor. Furthermore, the origins and the motive for the fields are very different. Public health originates from positions of privilege and can often reflect oppressive power dynamics with, for example, individuals who make public health decisions and set policy agendas not being individuals most disadvantaged. This resulting in the exploitation of the knowledge of those most disadvantaged in order to advance a scientific or moral agenda. And although there has been a rise in approaches which center social justice and restorative justice within the field of public health, the common practice and even just the terminology such as community-based participatory reflects a distinction which situates the community as participants. This dynamic is completely incongruent with the principles of disability justice, which prioritize leadership of the most impacted, collective access, and collective liberation. There have been emerging explorations of how critical disability and/or disability justice critique of public health could be applied, especially in the wake of COVID-19 pandemic, and with a general shift of public health to consider environmental justice, social justice, and other frameworks of health beyond the biomedical framework. Pictured here are a few images of example texts, such as the Public Health Perspectives on Disability, the Disability Justice and Public Health Emergencies book, and an article on structural ableism in public health and healthcare. So today I will attempt to explore caregiving in the rural context through both a public health and critical disability lens, aimed at answering the question, what are the implications of applying a disability lens to public health on caregiving in the rural context? So what is the current state of rurality in America based on the public health data available? There are a significant number of people living in rural areas that have disabilities. Rural communities have greater instances of poverty, high prevalence of comorbidity of chronic disease. Rural counties also have higher rates of mortality than urban areas, and approximately 1 in 5 rural residents in the US identify as being BIPOC. There are also significant barriers to caregiving access and supports, and multiple national priorities have been set by the US Health Resource Service Administration that are specific to the rural context, such as improving long-term services, transportation, housing, and more. Our question today is important because people living in rural areas of America experience place-based challenges and barriers that are exacerbated by social conditions and systems of oppression. A focus on caregiving across the care continuum is a recognition of our interdependence, which aligns with the disability justice rhetoric. And ultimately, public health and social service fields are in a position of power over systems and many resources. Applying a critical disability lens to public health practice within these contexts may provide a pathway to safeguard further harm and build a brighter future. In thinking about caregiving through the lens of disability, we see that critical disability, CRIP theorists, and disability justice scholars often position care within the context of interdependence, which centers people with disabilities as being caregivers as well as care recipients. And it further contextualizes care within the community and explores the possibility of centering a CRIP queer approach to care, such as care webs, which are collective, collaborative access models to care. Definitions of caregiving are often broad, inclusive, and relational, identifying care across a continuum and applied across contexts. Discourse around systems of sustainability and the importance of embracing sustainability, sustainable pacing, and a disabled pace of time is also evident. Where prioritizing sustainable care practices for self and community can be seen as a form of activism and resistance to an ableist capitalist system that actively works to eradicate disability and benefits from the death and degradation of disabled people. Disability scholars might also be critical on how care work can promote violence and oppression. In Kim's work on curative violence, we see narratives of how family carers in pursuit of quote unquote cure, an ableist value, might in doing so take away autonomy and inflict violence and oppression on disabled individuals. Scholars also critique the industrialization and institutionalization of care, both historically and currently, as a form of carcerality, which promotes violence and eugenics. And lastly, for today, disability scholars might critique the inequalities of paid care work across multiple social systems of oppression, where we see the exploitation of care work, especially amongst those most historically disadvantaged. Public health scholars often contextualize care within a capitalist politic, defining the role as paid or unpaid, if it is formal, such as trained or done by a professional, or informal, such as care from a family member or friend. Public health is predominantly concerned with caregiving as a service, a workforce, and a health or resource burden. The field prioritizes empiricism in measuring, quantifying, and qualifying care work, including assessing degrees and duration of care as either substantial or normative. Measuring often includes capturing types of tasks necessary to care provision, such as bathing or cooking, or time in the day needed to provide care. Quantifying often includes descriptions such as primary care provider or assessed based on things like if a carer lives with a care recipient. Qualifying often includes the disease or disability of the care recipient and how this might require substantial care or not. Public health agendas are often concerned about access to care institutions and view access to care and health as human rights, which translates to their concern regarding caregivers, justifying the importance of studying caregivers because of the rising prevalence of care recipients, such as an aging population, which leads to a prevalence of caregivers in the society. This becomes important since data shows caregivers have increased rates of chronic disease and morbidity and mortality, often discussed in tandem with a potential resource use or need based on risk of health burden. The role of caregiver then becomes important because of the impact it might have on society. Public health also often prioritizes unpaid work within the context of economic benefit and burden, with many public health agendas discussing how to keep carers working or able to swiftly return to work. So when discussing rurality from the disability scholar perspective, we see a centering of personal narratives surrounding social conditions within the rural context. For example, memoirists Eli Clare and Susan Krieger discuss the complexities of disability, rurality, and intersection of social conditions and affordances in their memoirs. We also often see a centering of embodied emplacement within the process of defining rurality, which centers the interdisciplinary interdependence of bodies and highlighting the importance of language and narrative in the placemaking process, particularly within rural environments that traditionally privilege mobility. Some disability scholars are concerned also with the practical and structural interventions allowing people with disabilities full access to rural life, and center social intersectionality and systems of oppression specific to the rural and agricultural context. For example, they might be concerned with racial and class disparities related to exposure to environmental toxins pervasive in agriculture. They may also consider larger politics of place, such as classism and poverty, as debilitating. For example, Eli Clare in his memoir, Exile and Pride, discussed the role of logging and fishing industry and exploitation of both nature and rural labor, pointing to how such systems are debilitating. A public health perspective to rurality often defines rurality within the context of existing political structures and governments. For example, the use of root codes is typical and based on a scalable measurement of rurality, the population size. Language such as frontier, population density, critical access are often present, which further contextualize the rural experience within existing political structures. Public health scholars are most concerned about things like access to healthcare, institutions and capitalism, or institutions and capitalist infrastructures, such as hospitals, government agencies, nonprofits, and existing extension agents. They prioritize addressing resource constraints, things like addressing systemic issues of poverty, including access to training, jobs, and transportation. And recent public health efforts have begun to consider intersections of health and environment and the resources needed, especially in the face of evolving environmental changes and increased environmental-based health risks. Public health often centers utilitarianism and healthism through striving for disease prevention, health promotion within rural communities, predicting population change, and healthcare resource need. So reflecting on the congruence between the two fields of the critical disability studies public, as both prioritize the interrelation of systems, a social ecological model could be utilized to identify entry points for the principles of disability justice. And so, at the overarching macro level of community governance, the disability justice principle of leadership of the most impacted could inform public health rural caregiving policy generation by urging public health initiatives to prioritize co-design that centers people with disabilities and care ethic. And cited here is one example from an Australian context. The meso-level anti-capitalist politic principle could be applied in the redesign of institutions such as public health supports and programs to center interdependence of care and crip time rhetoric. I've cited here a personal narrative of disability and caregiving from Shazin, which further explores crip time and institutional levels. At the micro level, we can recognize wholeness through integrating existing health equity principles into individual public health practice by embracing a strengths and assets-based approach. And I know I'm coming close to time, so I really want to get to this slide that ultimately the examples just provided here are just that. There are a few examples. And really, this is a precipice of interrogation and a critique of public health by exploring knowledge generated through disability studies. I want to urge that this is not an advocation or prescription for co-opting, taking, abstracting the vision and values of critical disability studies into public health practice. This is not the answer and never will be the answer. And I want that to be clear. This presentation is meant to be an exploration and consideration of potential access points for engaging and prioritizing a critical disability lens for critical reimagining of caregiving within the rural context. These are my references because knowledge keepers, knowledge sharers. Gotta really love all of these people who I am. And then thank you.
Thank you so much, Kate. You are fabulous. Thank you for sharing so many resources and so much insight and wisdom. I welcome folks in the chat. We do have few minutes, just a handful of minutes, but I wanted to start you off, Kate, with a question, if you could, for illuminating the additional challenges faced by rural communities when seeking public health assistance. Because rural communities are so varied, how might you encourage participants to better understand the complexities you described without treating all rural communities as a monolith?
I think you are so right that rural communities are a monolith. They are not the same, especially when we're thinking in our nation, in a state, across contexts, across nations. And I think that public health right now does treat rural communities not in a monolith. So we think about the application of ROOK codes, and so even leaving out certain places that have rural components to them too. And I think that it really centers on engaging in disability leaders who can inform and co-design policies and really put in place a co-design approach, and really thinking about reframing public health generally. I think is really just the point. And why I think that it's important is because so much resource and so much power and policy are in the context of public health and social welfare. And so without the voice of disabled people or people with disabilities present and able to engage, and especially within the context of rural settings, and especially individuals who are caring, people who have disabilities who are caring, who are being cared for, it's just really important to have those narratives. And I think, again, we've seen that through a lot of the presentations today, the importance of narrative. So even those stories shared is really important.
Thank you, Kate. That was fabulous. We have two more questions. I think we have enough time for them. From one, in your estimation, how are we in this country, the United States, although if you want to speak globally, please do so, doing on the macro and meso levels?
I think that like there is a lot of concern right now. I think, especially within the American context, as we're seeing things shift over the current administration, a lot of individuals within the rural setting rely on public health care and public systems to as a support. I think that that's really that macro level. I think that when we look at national care strategies across the global north, we see a prioritization of care work and kind of this linking of care recipients with caregivers. And so not an understanding of care as a dynamic continuum that happens across the life course, that that you can be a carer and a care recipient or at the same time. And so I think that at that macro level, that's just not a part of the discourse, that it doesn't exist, and so it needs to exist at the discourse at the macro and at the meso level too, at institutions providing services. And I think that often state level in America could be an opportunity for that, and it really isn't. There's a huge gap there. It's like just dismal, unfortunately, and that's why we need to have these conversations.
With that, we have one last question. If you could answer briefly. The person says, thank you for a great presentation. Curious what your next steps will be to further explore this important topic.
Yes, thank you for asking. Yes, I'm my first year of my PhD program, so this will be incorporated into my dissertation, and thinking especially on policy to practice. Yeah.
Thank you so much, Kate. Thank you for everyone in the audience for your fabulous questions. Thank you for attending. So grateful for you to be here with us today.